This program is brought to you by Emory University.
Good morning. Good morning and welcome to Cardiovascular Grand Rounds. I looked at the schedule for this week and was excited to see who our speaker was because whenever Dr. Nanette Wenger speaks, it's a treat. And I would encourage our trainees to listen to her message, listen to her passion, her organization. I was at a Emory alumni event in the last 2 years where she was honored, and my wife, who's a physician, turned to me and said, of everybody at the med school, she gets it. She understands what it's all about. Dr. Wenger, I actually listened to a YouTube this morning driving in that Rob Califf did on famous cardiologists and their lives and their values. She was the one of two daughters of Russian immigrants. She grew up in New York City. Her mother was a great artist. Her sister ended up in Alabama. Dr. Wenger came to Atlanta in 1958 because her fiance at the time, Julius Wenger, had accepted a job at the VA as chief of gastroenterology right out of fellowship training. She went to, Nanette went to Hunter College in New York City and then later to Harvard. She was in the 6th class of women at Harvard, and it's interesting to hear her talk about those times. She felt very supported by her classmates. She later did her training at Mount Sinai and came to Grady in 1958. And many of you know that Grady at the time was a divided hospital. There was the black side of Grady, the white side. It was a segregated hospital. And I think our leaders there realized that the patients there were people, and that they were all important, and certainly that has been one of the things that Dr. Wenger has taught over the years. So she values people, but what you'll hear in this talk is that she also understands that people are people, but that all of us are different, and that we have different needs and desires, and that comes into what we look at in our health care. So I'm sure we will learn a lot from her this morning. I encourage all of you to YouTube the Rob Califf interview of her, and also if you YouTube, there's a Grady Gala where she was honored as a sage, where it talks about her coming to Atlanta and what she's done and what she continues to do. Nanette.
Thank you so much for that fantastic introduction. What I want to do is to talk to you a little bit about geriatric cardiology. And it hasn't been that many years that the two terms have been joined, because geriatrics was over here, cardiology was over there, but now I think we see it as a joint venture. These are my disclosures, and I want to start out with a few cultural resources that will give some background to our discussion. From the Chinese, we hear that old people are as valuable as precious stones. The Italians say that retirement is like a second childhood. The Lebanese say, he who has not an old man in his household, let him buy one. Sweden, we hear aging is like a tree in the fall. The leaves fall off, but the trunk is still strong. The Portuguese tell us the old pan is the one that makes good food. And the Spanish say that the heart doesn't age, only the skin shrivels. And essentially that is the background for some of our discussions today. I want to highlight why the demography is important. It's simply that we've seen an unprecedented growth of the elderly population worldwide, and as I will show you, aging predisposes to cardiovascular disease. By 2030, almost 20% of our population will be Medicare individuals. And now there are 19 million older than age 85. And globally, what we've seen between 2005 and projected to 2030 is a 150% increase in the population over age 85. That is our fastest growing subset. So that if you think about your clinics, about your laboratories, about your intensive care units and your surgical suites, you'll realize that the prototype US cardiology patient is really an older patient. And the benchmarks that we're using are not the same now as Medicare does, so that over 75 is old age and over 85 is very old age. But I think the important background feature is that the aging changes result in clinically relevant differences in physiology and organ function, but particularly in multi-organ reserve. The population currently, the Medicare population, accounts for more than 85% of all cardiovascular deaths, 65% of cardiovascular hospitalizations, 2/3 of the hospitalizations for infarction, 3/4 of the hospitalizations for heart failure. And as we look at the risk from all of these problems, the attributable risk is highest in the senior population. What does that mean? It means that favorable interventions have the greatest potential to favorably affect morbidity and mortality. But we have to realize the downside is that this is counterbalanced by increased iatrogenic risks. So we are really playing a balancing act. So then what do I see as geriatric cardiology today? And essentially, it's the practice of cardiovascular medicine adapted to the needs and complexities of older adults. And the complexities are several. There is multimorbidity. 68% of older adults have at least 2 additional chronic conditions. Polypharmacy, as you know, is characteristic. We are learning so much more about frailty. Cognitive impairment is a complication. Functional status and ability and disability, probably a pivotal area. And then we really must learn to address the social, financial, and psychologic dimensions of aging. And when we talk about patient-centered care, which is our buzzword this decade, that is required to embrace the complexity of a geriatric population. The challenge that we have is that there are relatively few data-driven studies to guide care for this very vulnerable population, because most of our geriatric patients have outlived the current data-driven recommendations. And what we realize is that with aging, there is a lesser capacity to tolerate, and as a matter of fact, to desire medications, devices, procedures, as compared with a younger population. And it is not just the cardiovascular problem, but rather the coexisting conditions that affect health-related quality of life and indeed survival. So what we will have to focus on is patient-centered outcomes and priorities in contrast to disease-specific outcomes. And remember, when we look at our guidelines, what do they talk about? They talk about disease-specific outcomes. This is the commercial, and it is from the section on geriatric cardiology, the American College of Cardiology. We have put together a cardiovascular curriculum designed for specialists and other clinicians who care for older patients. It teaches practitioners some of what I'm going to very briefly summarize today. 17 ABIM maintenance of certification part 2 points. The list of the modules is on this slide. It's an online curriculum. It's available to all practitioners. Each module takes you about 30 minutes to complete. There is a test with each one, and you get 17 CME or CNE credits. Most importantly, it's free. And what we plan to do is that anyone who completes all of the modules will be on a list that is posted online so that both your colleagues and your patients can realize that you've completed a curriculum in geriatric cardiology. This has taken us about 2 years to put together, and I'm really very proud of it. Okay, back to content. I think the reason that older adults are so susceptible to cardiovascular disease relate to so many of the cardiovascular changes of aging. The increase in central arterial stiffness increases afterload. Endothelial function is decreased with a lesser ability to vasodilate. There is a decreased and delayed early diastolic filling that results in increased dependence on the atrial contribution of ventricular filling, which is why our elderly patients often have many more symptoms with the onset of atrial fibrillation. There's a decrease in sinus node pacemaker cells and the resultant sick sinus syndrome. And beginning actually at age 29, there is a progressive decrease in aerobic capacity as measured by VO2 max. There's lesser beta adrenergic responsiveness, less benefit from any form of preconditioning, and lesser angiogenesis. Now, in addition to the changes in the system, there's a problem with the diagnostic assessment. The typical cardiovascular symptoms for which we see patients, chest pain, dyspnea, dizziness, exercise intolerance, are less specific because of the age-related physiologic attrition and because more than half of the patients have 5 or more coexisting chronic conditions that may result in these symptoms. So what we see on one hand is that cardiovascular disease may be underestimated and treatment delays of our elders are notorious, somewhat because we have some uncertainty about the therapies, and I'll go over some of the uncertainties subsequently. But the disease is also overdiagnosed and overtreated, particularly in the imaging area. Sometimes age-related changes in the vasculature and physiologic changes, which would signify disease in young individuals, are really just changes of aging. And also, the presenting complaint, falls, dizziness, syncope, weakness, may be part of geriatric syndromes rather than manifestations of cardiovascular disease. Let me give you just 3 examples that we will build upon later. It's simple to diagnose atrial fibrillation, but the complex decision is which 85-year-old should receive anticoagulants and which anticoagulant to use. Again, the diagnosis of severe aortic stenosis has very established criteria, but the complex part is the assessment of what is the degree of frailty and multimorbidity that is prohibitive for the application of TAVR. And then we have very good clinical and angiographic indications for PCI. They're very well established. But the complex decision is when dementia or multimorbidity should preclude the application of this intervention. Now, let's think about our elderly patients and their goals of care. Remember that the randomized trials that we use as our evidence base typically assess mortality endpoints. But elderly patients may not view length of life as their highest priority. And when elderly patients are queried as to their health goals, first is independence in daily living. Next is functional capacity, specifically the ability to ambulate. A decrease in hospitalizations, anything that will keep them out of hospital, and a decrease in symptoms. And obviously, you've heard all of your patients voice psychosocial and financial burden, both to themselves and to their family. So that the elderly patients may not perceive randomized trial endpoints really as being personally beneficial, and are quite concerned with the manner and quality of death. As an example, an ICD can prevent a sudden, painless death, and rather have the patient die from highly symptomatic heart failure, myocardial infarction, cancer, or non-cardiac causes. And one of the tragedies I see is that ICDs are rarely deactivated in hospice care. That's something that should be one of our priorities. Now, what are the pitfalls of the disease-specific guidelines? And if you look at those that you have, they're a drawer full of them for every disease we treat, for elderly patients with multiple conditions. And the fact is that if you look at all of the evidence-based data on individuals over age 80 are virtually absent. Many of the randomized trials excluded the elderly participants, and even when they were included, there was systematic exclusion by the entry criteria for those with comorbidities and complexities. Stated very simply, The elderly individuals in the randomized trials differ substantially from our community elderly patients, and that is what makes our evidence-based care perhaps less certain. What I'm going to do is to go through a few examples from a few disease states and just highlight a few that I think are important. First is the perioperative management for non-cardiac surgery, a major reason for which we are consultant. And what do we use as the basis? We use the RCRI, which gives you a point for ischemic heart disease, heart failure, stroke, diabetes, elevated creatinine, and the location of surgery. And we know that if there are no predictors, the risk for the cardiac death or cardiac complications is 0.5%. If there are more than 3 predictors, it's greater than 11%. That is, for an elderly patient, a totally incomplete assessment. We know that the rate of surgery is 4-fold higher in the elderly population, and in that population, age over 80 years is an independent predictor both of perioperative complications and of death. And what we begin to see is that it's the functional status and the comorbidities rather than chronologic age that determines perioperative risk. You've just seen the RCRI. It doesn't address frailty, it doesn't address cognitive function, it doesn't address multimorbidity. And when perioperative complications occur, pretty obviously, they increase the length of stay, they increase the likelihood that there will not be discharge home, but rather to transitional care or chronic care, increase the risk of disability and dependency, lessen the quality of life, and most importantly, perioperative complications are associated with a lesser likelihood of recovery to the preoperative physical and mental state. So basically, my message is RCRI is incomplete evaluation. And in terms of perioperative management, we often don't think of delirium, but it may be present in up to 1/2 of the surgical patients, and we see it in at least 3/4 of patients in an intensive care unit. And importantly, it doesn't immediately and completely resolve because in many cases there are persistent cognitive deficits and functional decline. We see atrial arrhythmias, in particular atrial fibrillation, certainly most with valve surgery, but we see it with non-thoracic surgery as well, with the increase in stroke risk and the prolongation of hospital stay. And then we have the challenge of pain control, because both inadequate pain control on one hand and excessive analgesia on the other increase the risk of perioperative complications. This really requires very fine tuning. Now, let's talk about prevention. And what I want to do is simply just show you the picture of these 2 individuals. Both are 87-year-old women. They don't have known cardiovascular disease. You see their blood pressure, you see their hemoglobin A1C, and you see their LDL. Now, for which of these 2 are you going to do preventive interventions? And my message that is, I think, quite clear by these visuals is that you have to individualize. And it really is your assessment of the patient plus the patient's assessment of what she chooses to have. When we look at hypertension, we see it's a disease of the elderly, so that in your patients over 75 years of age, both the men and the women, the majority of them will have hypertension. And we know that isolated systolic hypertension and widened pulse pressure are phenomena of aging. And obviously, the systolic hypertension is a greater risk than the diastolic hypertension. But the goal blood pressure, I think we could spend an hour discussing the various guidelines, and particularly the very recent Sprint guidelines that suggest a goal of 120/80. But I expect that the only thing that all of us in the room would agree on is that when you do pharmacologic management of hypertension, you start with low dose, with slow increments, and most importantly, this is not solely a medication issue. Lifestyle modifications are quite important. What about physical activity? Sedentary lifestyle just increases with advancing age, and in every one of the studies, a decline in aerobic functional capacity is associated with an increase in mortality. The combination of aerobic and strength training decrease but don't reverse the age-related decline in aerobic capacity. But physical activity, what are the benefits? There are benefits on blood pressure, on lipids, on glucose, on arthritis, on neurocognition, on exercise capacity, quality of life, and independence. Now, if we could put all of that into a pill, we would be giving it to every one of our elderly patients. But the important feature is that part of your counseling is to encourage physical activity for these multifaceted benefits. Now, what about statin use at elderly age? I could cite for you an impressive array of trials of efficacy and safety. They decrease mortality, they decrease coronary events, they decrease stroke, they decrease DVT. And as an example, in the Jupiter trial, the elderly patients actually had greater rosuvastatin benefit than the patients under age 70. But what if that statin is the 8th pill in a very complex regimen? How much relative benefit will it provide? What about the nebulous muscle aches and the decrease in mobility? And we just said the benefits of physical activity, and even the medication costs. So again, this is part of a discussion we have with our elderly patients. Let's go on to stable ischemic heart disease. And as background, we know that the older adults have a very high prevalence of triple vessel and left main disease, but that their anginal presentations are atypical. They may simply be nausea, vomiting, epigastric discomfort, activity intolerance. And in general, if we're going to generalize, pharmacologic testing is probably a more useful option for diagnosis and prognosis, simply because multiple comorbidities limit the ability to perform an adequate exercise test. Secondary prevention, no difference by age. But then the decision about revascularization. You have a high-risk older adult with refractory symptoms on optimal medical therapy. And what we will weigh with the patient are the individual risks and benefits, the contribution of the comorbidities, the goals of care. What is it that that individual patient wants? And a very important component of that is the current level of function compared with the anticipated level of function if there is an intervention. Now, what we've seen, and our interventionalists will tell us, is that there's been an enormous increase in PCI in patients older than 75 over the last few decades. And despite the fact that these elders have greater bleeding and stroke risk, there is comparable angiographic success and clinical benefits. And again, the absolute benefit may be greater in older patients because this is the population with the greatest risks. The data on bypass surgery, patients over age 80 as a group have a greater extent and severity of coronary disease, are more likely to have left ventricular dysfunction, importantly, more likely to have concomitant valve disease and may have had prior surgery. And the increase in these comorbidities are not included in many of the surgical risk scores. The score 2 that the Europeans use includes poor mobility as one of the assessment components, and the STS score uses gait speed essentially as a surrogate for frailty, but that does not fully measure frailty. And none really assess global functional capacity or dementia. We know that the operative mortality is double in octogenarians compared with the younger population, but importantly that the discharge home rather than to a transitional facility is half that of younger patients. And I think that's something our surgeons routinely will discuss with the elderly patients. Acute coronary syndromes. A third of myocardial infarctions in this country are in patients 75 and older. 11% of them are older than 85. STEMI, as well, is less common than NSTEMI, but the absolute numbers of STEMI do increase with increasing age. And the challenge is that the older patients, but particularly so the older women, characteristically present with a non-chest pain ischemic symptom. They may present with the GI symptoms of nausea, vomiting, abdominal discomfort. These represent myocardial ischemia. And commonly, they will arrive in the emergency room with severe dyspnea, fatigue, dizziness, syncope, confusion, altered cognition. The important thing that our emergency department colleagues have realized is that the EKG still remains important in recognizing the STEMI, but even that EKG diagnosis is often complicated by abnormalities on the baseline cardiogram of LVH, prior infarction, atrial fibrillation, conducting disease, and the fact that STEMI in older adults is rather common in presenting with a new left bundle branch block. Again, a diagnostic dilemma. But the fact of the matter is that reperfusion is associated with better STEMI survival in older adults, and no question that PCI is favored over fibrinolytic therapy. In the days when we did a lot of fibrinolytic therapy, we had an almost unacceptable amount of hemorrhagic stroke. That is far less with PCI than with fibrinolysis. And again, in the days when we were doing a lot of fibrinolysis, there was an increased risk for myocardial rupture in the population over 75 years of age. The older data show that that was 17% compared to about 5% of the PCI population. But the major benefit that we see in the STEMI revascularization is a decrease in recurrent ischemic events and a decreased need for subsequent target vessel revascularization. But also in the end-STEMI population, there's a greater absolute benefit for early invasive management even than in younger adults. And the elder patient with end-STEMI, with the so-called conservative, non-invasive management, has a higher risk of adverse outcomes. Obviously, you're going to weigh the comorbidities, but there is major benefit of revascularization. But we always worry about bleeding risk, and older adults have an increase in bleeding risk. There's probably an age-related vasculopathy that impairs vascular healing. There's some loss of anatomic vasoreactivity, and immune incompetence may play a role. But the patients who have anemia, renal dysfunction, heart failure, and diabetes, and these are rife in this population, have a greater bleeding risk, as do women, individuals of low body weight, history of bleeding, etc. But the catheter-based interventions are really the focus for much of the bleeding that we see, as well as inappropriate dosing of anticoagulants that are not adjusted for weight or renal function. So that for STEMI in older adults, we're fortunate in Atlanta that we have a quite good community system for acute reperfusion. It's much more of a challenge in the rural areas. But the important thing is that we have to have the geriatric dosing of guideline-directed medications to avoid bleeding complications. And very important, once the patient leaves the cardiac catheterization laboratory, is early mobilization and referral to cardiac rehabilitation. And that is where often we find that we are not doing as good a job as we should. And remember how many transitions of care we have in these elderly patients, from the emergency room to the cath lab, to the recovery suite, to the intensive care, to floor care, possibly to a nursing facility. Communication, information, medication, reconciliation. How many times must that be done to see that we don't trip ourselves? Now, what about the issue of anticoagulant and antiplatelet therapy combined? In the acute coronary syndromes, what do you do in the older adult who is already anticoagulated for atrial fibrillation? We use the dual antiplatelet therapy after PCI and stenting, and in one moderately small study, clopidogrel and an oral anticoagulant, dropping off the aspirin, was as effective as triple therapy and had less bleeding. I expect there are going to be 1 or 2 studies at AHA doing this comparison to say, do we need the increased risk of triple therapy? Which of the medications can be dropped? And one of the issues, just looking at a very subset analysis within the Trilogy study, is that baseline frailty assessment in the population over age 65 was independently associated with an increase in cardiovascular death, MI, or stroke, so that these are the patients that need very early follow-up, and very early follow-up following the hospitalization. And sometimes when they are discharged to a transitional care facility, that quality follow-up does not happen. Let's go on to heart failure, because that's predominantly a disease of older adults. It's often inadequately recognized and treated because the early symptoms are often attributed to aging or other conditions. But there are a few special issues that I want to highlight today. And that is that a small percentage of blacks carry an allele of the serum protein transthyretin, and that increases the risk of amyloid heart failure, particularly in that population, so we must be aware. There's an increased risk for hyperkalemia with pharmacotherapy because we underestimate renal dysfunction. We look at creatinine rather than looking at glomerular filtration rate. Remember that the levels of natriuretic peptides increase with aging, so that limits their diagnostic utility. We're all aware of the increased risk of digoxin toxicity, and the association of atrial fibrillation with heart failure in the elderly poses a number of problems. Again, a question that would have never been raised 20 years ago, because A, we didn't have the support, and B, we didn't have this large elderly population. But should there be mechanical circulatory support as destination therapy? In general, age greater than 80 is considered a relative contraindication, but this discussion must come up. The most important thing that we must see happen is comprehensive discharge planning, post-discharge support, advanced directives in this very vulnerable population, and, if appropriate, referral to palliative care. We're seeing heart failure with preserved ejection fraction as predominantly a disorder of older women. And we really don't have a proven effective therapy yet. It may be that the aldosterone antagonists are going to emerge, but we certainly need more evidence. Now, we've had some good news, though, in the heart failure scene, because in the Paradigm heart failure study, the combination of valsartan and the neprilysin inhibitor sacubitril decreased cardiovascular death, hospitalizations, all-cause mortality, and there was similar benefit in the population older than 65 and the population older than 75. Those were specific sub-analysis, as in a younger population. What about ICDs? And I think that becomes individualization in terms of your estimating risk and patients determining whether or not they want the procedure or whether or not they want the potential shocks. Valvular disease. And we've come to realize that calcific aortic stenosis is the most common disease that we see, but it rarely occurs in isolation. It usually has concomitant coronary and peripheral arterial disease. But studies have shown that the progression is more rapid at older age, so that these patients must be followed a bit more carefully. And all of the bad things increase the progression: smoking, dyslipidemia, diabetes, and hypertension. But again, we must be careful about diagnosis. Signs and symptoms difficult to recognize because physical activity decreases with aging, and therefore the symptoms are often attributed to other conditions. And then the decision that we and the surgeons make with the patient, and that is a mechanical versus a bioprosthetic aortic valve if valve surgery is undertaken. And the questions are the durability of the valve compared with the bleeding risk of anticoagulation. And I think today the weight of the evidence favors the use of a bioprosthetic valve. Now, if the patient has atrial fibrillation and is already anticoagulated, and that anticoagulant is warfarin, that changes the weight a little bit. And the fact of the matter is, even though the older adults have a greater perioperative morbidity and mortality, they have a greater gain in long-term survival and life quality. And I think those are important data. Now, what we see with aortic valve replacement is that in the last decade, it's the older patients that have had the greatest increase, and with valve replacement going from the 1990s to the present, a declining mortality. So we are doing better in this population. And then for this group at Emory to talk about TAVR is like bringing coals to Newcastle. But I think that what we see, and I'm just going to pick up a few items there, is that in the STS-ACC registry, there is benefit even in nonagenarians, but that an STS score over 15, frailty, porcelain aorta, prior chest radiation, all of these decrease the likelihood of benefit from TAVR. I think the importance of the registry is that they are actively now collecting baseline and longitudinal frailty and activity limitation assessments. And I think that within the next year or so, we're going to have a better risk-adjusted mortality model that will help us and our patients reach informed decisions. Atrial fibrillation. Median age of the patients is 75 years, and about a third of them are older than 80. There's about almost 10% prevalence in the elderly. And you know, we basically agree that oral anticoagulation is appropriate with a CHA2DS2-VASc score over 2. But age over 75 gives you that score of 2, so you are already in the anticoagulant sphere. Some very interesting information, because people say, well, I'm afraid of anticoagulants, let's use aspirin. There's some interesting information from the old BAFTA trial, the old anticoagulant trial, comparing at physician discretion, not randomized, aspirin or warfarin. There was almost a 4% one-year stroke risk with aspirin, less than 2% with warfarin, but no difference in major bleeding. So significant aspirin bleeding, even by physician choice in that study. And I think going over the meta-analyses of the NOACs that we use currently, that they're equal or even superior to warfarin in the elderly population in decreasing stroke risk, decrease in major bleeding, some potential increase in gastrointestinal bleeding, but the major benefit is the decrease in intracranial hemorrhage. What about device-based therapy? Pacemakers, no difference than in younger patients. ICD, very important new variables, and that's life expectancy, lifestyle factors, personal preference, and as I said earlier, we must discuss deactivation at end of life. But biventricular pacing is reasonable if there's a pacemaker in place to improve function and quality of life with advanced heart failure. What about abdominal aortic aneurysm and peripheral arterial disease? We have the screening recommendations in males 65 to 75, but the fact is that peripheral arterial disease is present in about a third of the population, and it's often asymptomatic. Risk modification, very important, because PAD is associated with an increase in cardiovascular risk. And age greater than 70, an independent risk factor for PAD. We must screen these patients. I call to your attention the limitations of ABI for diagnosis when there are calcified, non-compressible arteries, and possibly a toe brachial index can be used. And for the patients who can't exercise, timed whole walking may be an extremely valuable, simple, inexpensive test to assess function and to assess response to therapy. Venous thromboembolism, very common, greater than in younger patients. Aggressive prophylaxis, early mobilization. But what I want to emphasize with pulmonary embolism, less often a presentation with chest pain, much more syncope at elderly age. So any patient with shortness of breath and syncope, pulmonary embolism should be at the top of your list. And these patients have a higher hospital mortality. I'm not going to spend much time on stroke, except to say that the effectiveness of intravenous TPA is not well established. With stroke, the emphasis is prevention, and that's aggressive blood pressure management, anti-thrombotic prophylaxis in patients with AF, and now there are increasing recommendations to screen women older than age 75 for atrial fibrillation as a etiology of stroke. Our surgeons do carotid duplex screening before elective bypass surgery in the over 65 population. And again, secondary prevention, certainly the newer agents are as effective as warfarin. And when we talk about carotid disease, It seems that after age 70, there is a better outcome than with carotid stenting. Having given you these examples, let me share with you what some of your challenges and mine are. The fact is we don't have metrics yet for geriatric risk assessment, and that's one of the works in progress. We don't really have metrics for how we use multimorbidity. We check frailty by grip strength and gait speed, but the specific metrics and the risks are not there. We know sarcopenia is a major problem, and we get that with the fall history and orthostasis. There are some tests of cognitive impairment, but they are probably not used as well as they should. And then how do you measure functionality as it relates to the maintenance of independence and the avoidance of dependency, define the social limitations and stressors? So what we are trying to do is to incorporate the physiologic age with the biologic age. And I've given you some examples of how we do it in specific diseases. So while we talk about patient-centered care, this is absolutely critical in geriatric cardiology. You have to assess the cardiovascular risk in the context of the aggregated age-related risk, and then determine with the patient realistic goals, realizing that there are problems with non-cardiac comorbidities, with functional capacity, with quality of life, so that you can select with the patient those who are most likely to benefit from a particular therapy. And I think we have to assess the utility of diagnostic testing relative to our overall management plan. Do we use simple or do we use extensive tests? What are the impact and the consequences of the test results? And we have to think about that before we order any particular test. And then the patient preferences. And the geriatricians are telling us that we should have something documented in our electronic medical record that is shared with all the patients' caregivers of the end-of-life preferences, of advanced directives, of durable power of attorney, of discussion of palliative care options. And this should not be done at a crisis in the hospital. This should be done on an ambulatory care encounter, and we should have the opportunity to teach both patients and their families about what their reasonable expectations should be, given whatever the specific cardiovascular disease is and the comorbidities. Let me go over a few of the lessons that I think I've learned over time. Certainly, we've seen this tsunami of aging worldwide, and we see that the cardiovascular disease and adverse outcomes increase with aging. It is the physiologic changes of aging that increase the vulnerability to cardiovascular disease, and what we have to do is routine assessment of cognitive function, of independence or function, and frailty. Must realize that concurrent aging changes in other organ systems decrease an elderly individual's capacity to respond to stress, and that is associated with an increased risk for complications and with worse prognosis. There is a disproportionate age-related therapeutic benefit, but the absolute mortality benefits, because these are high-risk patients, may outweigh morbidity and mortality risks. Realize that quality of life function, independence, and avoidance of adverse effects are more significant endpoints in older patients, lesser hospitalizations. Those are not captured in the endpoints of many of our clinical trials, and they will have to be. We need a patient-centered treatment goal. Beware of drugs. Adverse drug events account for 1/3 of the hospital admissions of older adults. And we have to decide a threshold for invasive intervention and strategies to minimize adverse events. Attention also to specific cardiovascular syndromes that predominate in seniors, such as isolated systolic hypertension and heart failure with preserved ejection fraction. Finally, let me try to summarize the many points I've reviewed this morning. Mainstream cardiology has become geriatric cardiology, and because of that, what we must learn and acquire is a systematic approach to incorporate age-related complexities into routine clinical decision-making, and we have to adapt the standards of evidence-based care to older patients. What one of my colleagues said is that between the guidelines and the patients, we need a physician who can think and reason. We have to have a synthesis of multisystem aging, comorbidities, polypharmacy, psychosocial factors, and personalized preferences. Those are the individualized approaches to care that will assure us better outcomes for our elderly patients. And I thank you for your attention.
Great, thank you. So as we look at what's going on in the United States with focus on quality metrics, that things do get adopted broadly across all ages, even though there may not be data to support it. And we can talk about trying to get more data by more metrics. Maybe we have more metrics looking at frailty and in the elderly, but at the end of the day, we only have so much time in our offices to deal with patients. And I think we had a grand rounds recently on right brain and left brain and how we need to be better observers of what is actually going on and really understand. So how do we deal with what is required of us, put upon us, often inappropriately in my view? I think some of the metrics that we're held to may actually interfere with the care of the elderly patient. I'd like to get your thoughts on that.
Well, as you know, MACRA is upon us, and all of the myriad regulations of MACRA have now been published. But I think that we must realize that the provider results will be based in part on patient satisfaction, so that we have to work with our patients to see what is it that they want, and maybe not only patient-centered care, but patient-preferred care may be the way we want. But there should be a way, if your patient says, per guidelines, hemoglobin A1C, for example, has to be measured every 3 months. Patient is very stable, says, blood draw is a burden, I don't want it. Can we do it every 6 months? There should be a way, if you document patient preferences in the record, that will override some of the quality measures. Now, what this assumes is that you spend enough time with the patient to identify whatever test or procedure, the potential risks and benefits, so the patient's made an informed decision. But I think that is going to become something that is considered, and if you've looked at that, 793 MACRA regulations, some of that is mentioned, but the devil is going to be in the details. But I think we're going to have to say, what is it that patient wants? And how much burden do the guidelines, per se, place on a patient? Because here I have a patient before me, and I have 9 guidelines, which say different things, many of which conflict. And the patient is the 10th guideline.
And I'd say this is a very typical Nanette Wenger, lecture, and it's very informative, very understandable, and very clinical applicable, and I thank you for it. The things that I'm impressed with is we talk about activity, and I think you're right, is that if you look at the thing that makes the most difference as we age is activity. But what I also see is that there are many obstacles to getting patients active. One typical thing I've run into is says, well, you need to walk more, you need to get up and walk, and then the patient says, well, doc, my hip just terribly painful when I walk. And so we've got to be able to show them other types of activity, that it's not all activity has to be walking. It could be upper extremity activity or something else. I think it comes back again to you saying you've got to be patient-centric in trying to do this. The other thing I think is frailty is we need to understand is a condition. I mean, it's not just a symptom. Frailty is, as you said, the problem we're having with it is trying to define exactly what it is. But it is related to sarcopenia. It's something that if we could predict, we'll save a lot of lives, because some of these people that look okay until you start doing an invasive procedure do not look okay. But again, thanks for your presentation.
Well, again, I expect that we're not using our physical therapy colleagues enough in terms of recommending activity. And these are the individuals who can specialize in showing patients what can be done for chair activity, for upper body mobility activity. And some of these things are very, very simple. We're not using some of the educational aids for physical activity that are available, the VCRs, we're not using any of the technology to help patients do some of this at home, or to help family and patients do some of this at home. And for many patients where walking is really a challenge, I think referral to physical therapy is very appropriate. What we've seen in the Atlanta community is an increasing number of senior centers now have pools. And many patients who can't walk on land can do pool aerobics and pool exercise. And I've been impressed how many of my Grade E patients will take advantage of this when their physician recommends aerobic exercise in the pool.
I agree. I think that, I think we could use a lot of help on this. We could use a physical therapist. We could use nutritionists, because weight loss is another big problem for these people. And probably all of you saw it, but yesterday there was a whole section of the Atlanta Constitution about aging in Atlanta and showing various things that are happening around the city. So there is a tsunami coming. We've got to deal with it. I think corporate America's began to recognize that it's out there too.
Nanette, a lot of the people who are older live in nursing homes and assisted living and so forth. And just when you mentioned getting the A1C measured and the corporate interest, my experience is that the A1C will always keep being measured in every other thing, because they can put the patient in a van, take them to the doctor's office somewhere or to the lab, get the A1C, bring them back. You get a bill, for the transportation, all this. My experience has been that we have a major defect in our assisted living situation in terms of health care. I mean, we can talk about what we do as physicians. You don't really see these people. They're now in the nursing home, and there's a nursing home doctor who comes by and signs forms once a week. I think there's just a huge gap here in terms of not only cardiac, but every kind of care in nursing homes.
Well, I think there's even a greater challenge in the skilled nursing facilities as it relates to older adults, because the current regulations for being able to refer someone to a skilled nursing facility is that they must be able to do X number of minutes of rehab in the course of a day. And if they can't do that, and often they can't do that on admission, then they can't go in. But that's the reason they're being entered into the skilled nursing. And I expect that one of the things that we should push for is to require that at entry to a skilled nursing facility, there be a baseline assessment of function, and then a plan of what is done to improve that function, and then a discharge assessment to see whether that functional improvement has been accomplished. Because if that function is increased, that has far better prognosis on independence than if they get the X number of minutes of whatever is required a day. There's an excellent statement from the American Heart Association on assessment of function in older adults that makes this emphasis on skilled nursing facilities, and we've not paid enough attention to that. Bob.
There we go. Good. I just want to raise one issue that has been an issue for us in elderly patients, and that is the need to suspend some of the advanced directives if we're going to operate on somebody. We need to be able to use the full range of our capabilities in that 3 to 4 weeks. Last 2 weeks ago, I had a terrible time persuading a family, including several physicians, that we needed to do a tracheostomy on an 83-year-old lady who'd been intubated for 5 days once you're intubated for 5 days and you're 83 years old, you're going to aspirate if we take out the endotracheal tube, unless you're really strong. And she eventually got her tracheostomy, and she's going to be fine. But that was a kind of a hurdle for many people, is the idea of a tracheostomy. They're thinking she's going to have a trach for a year. This isn't going to be good for her. But the temporary suspension of some of these advanced directives is critically important. And if we're not ready to do that, then we shouldn't go through the surgery. We need to be able to use the full range of our capacities in that interval.
Well, it's the same thing in the cath lab. For some patients who have DNRs, at least you want part of that suspended in the cath lab in case the patient needs to be shocked, et cetera. So I think you have to think through what might happen in the course of a procedure. You have to discuss it with the patient and family, then discuss what is a temporary suspension and when that temporary ends. That's, I think, what most patients and their families are afraid of.
Thank you, Dr. Wenger. You mentioned the recent controversies around both isolated systolic hypertension or widened pulse pressure, and then the risks of iatrogenic complications. In that healthy 87-year-old jogging woman in your slide, if she's untreated, are there certain medication classes you go to or avoid for that clinical entity, the isolated systolic widened pulse pressure?
I don't think we have any good comparative data. I think the early data on the isolated systolic hypertension related to thiazides, but we don't have comparative effectiveness data. And I expect that a lot of your decisions are based on the patient's comorbidities. If that patient has diabetes, I would really like an ACE, and et cetera. So the concept, I think, is gradual lowering of the blood pressure to level tolerated, and in the office, always measure orthostatic pressures. That should be an automatic in individuals in the Medicare age group.
Let me ask one question, Nanette. That I've seen that people that come in with hypertension, and some of these people have very high blood pressure, systolic 200 and all, but then if you look and see, they have no evidence of end organ damage. They don't have LVH. Their kidney function is still okay. Do you think there's a group of these people that actually tolerate these blood pressures and we can back off from treating them?
I don't think that we've been able to document that at all, and I expect that the majority of them have some degree of left hypertrophy, which, as you know, is a predictor of mortality. And again, their creatinines may be borderline normal, but their GFR is usually decreased.
I just have a hell of a time trying to bring their pressure down. That's what it is.
Yeah, again, it's just trying to do it gradually. And remember, lifestyle factors become very important: sodium restriction, exercise, and the like.
One question that Dr. Leon just texted to me a few minutes ago that actually has to do with a patient that we managed together, an 87-year-old female who has permanent atrial fibrillation, has had a His ablation, and she came to see me and was just complaining that she had quite a bit of bruisability of her skin, and it was painful, and that she just really did not want to take anticoagulation. And so I called Angel up and I said, what do we do in this situation? His response was that there's really not much data on patients above age 85 and anticoagulants, whether the novel anticoagulants or warfarin. But how would you personally approach that situation? Obviously, I mean, this lady's very active. She travels around the United States and even to Europe. Probably one of her fears is having a stroke, obviously. But she's also got a diminished quality of life because of pain under her skin. How do you approach that?
Well, again, I think that the nuisance bleeding with anticoagulants is as important as some of the major bleeding, but I expect that most of us view stroke as a point of no return. And that is the way I counsel my patients, that after you've had the stroke, you can't change your mind. And even though we have no data, we have few data past 80, almost nothing past 85, the stroke risk increases incrementally with aging, And she, each year, is going to be at increased risk of having a stroke, and therefore, what is the trade-off that she chooses to make? And she will ultimately make the informed decision. But I view stroke as a point of no return.
But is that so the risk from atrial fibrillation increases, the risk of falls increase as well in hemorrhagic stroke, and how do you factor that in?
I think someone estimated that in terms of falls and hemorrhagic stroke, you probably have to fall several times per week in order for the risk of hemorrhagic stroke to approach the risk of atrial fibrillation stroke. And I think we make great mistakes in looking at patients and saying, are they a fall risk, just because they may be unsteady or frail, etc. And the question we don't ask is, have you fallen? And no matter how frail and unstable the patient looks, if they haven't fallen in the last 3-4 months, I think their concept of fall risk is very, very different. It's not what do we think they look like, but have they fallen?
The preceding program is copyrighted by Emory University.